How about we listen more to patients
You know,
because they know their bodies and
absolutely. And, I've said this before. I had someone who relayed her own story about her pregnancy journey. And one of the things that she said that stuck with me is that when you're in a consultation with a physician, there are two experts in the room. There's the medical expert and the patient, because you are the expert where you're concerned. And so it's important that you get your message across. And we always say, if not, bring someone else with you to the visit, someone who can help to get across your points, whether that is, the trusted other or the third, having that person in the room to help to get your point across so that, as you said, so that the patient can be heard.
Hello, and welcome to 20-Minute Health Talk. I'm your host, Sandra Lindsay. While any maternal mortality is a tragedy we strive to prevent for every family, today we must confront the startling statistics that reveal a disproportionate burden on Black mothers in the U.S. This is a critical public health issue demanding our focused attention. Joining us is Dr. Dawnette Lewis, a leading voice in maternal fetal medicine. Leveraging over 20 years of expertise, she's the physician lead for the Respectful Care and Promotion of Safe Vaginal Birth initiative and an associate professor at Northwell Zucker School of Medicine. Dr. Lewis is deeply committed to fostering strong relationships with her patients and colleagues. On this episode, Dr. Lewis will help us understand the current landscape, systemic factors, and critical progress, including lessons from New York. We'll touch on behavioral aspects, policy priorities, and practical advice for Black mothers navigating their healthcare journey. This is an important conversation for a future where every mother receives optimal care. Dr. Lewis, thank you so much for joining us.
Dr. Lindsay, thank you so much for having me and for discussing such an important issue.
I'd like to start with our current landscape, where we are right now. So from your unique vantage point at the Center for Maternal Health, what is the current state of maternal health for Black mothers in the U.S. today? And what are the most pressing statistics and realities we need to understand?
Thank you for that question, Dr. Lindsay. I'd love to say that I thought we would be in a better place, but I think we're in the same place pre-pandemic, now post-pandemic. We do know that the United States, when compared to other well-resourced countries, has one of the highest maternal mortality rates, and that includes all birthing mothers. But we know that our Black birthing mothers, they have a disproportionate burden when it comes to maternal mortality. So I think, not that I think I know, for all women who are given birth, that the United States, it's a little bit more dangerous than other countries that are considered just as well resourced as the United States. We know that in the United States, that Black birthing moms are 2 to 3 times more likely to die in childbirth. And we know that number is 4 to 5 times that for New York City. And those numbers essentially have remained static, while in some populations there has been improvements in maternal mortality. We have not seen those same improvements in the Black birthing populations. During the COVID pandemic, for all birthing moms, we saw an increase in the maternal mortality. And after the pandemic, those rates went down to pre-pandemic rates. However, for our Black birthing moms, the rates are still disproportionately higher.
So what are some of the factors you think driving that? Why hasn't it gotten better for Black mothers?
It's an interesting question, and it's a question that we ask ourselves, as we do our day-to-day work in maternal health. And I think oftentimes the conversation always focuses on socioeconomic status to say that patients who are not as well resourced, that they have these increased risk or increased burden in pregnancy. But we know that for Black birthing moms, regardless of whether you're in a high socioeconomic status or you're in a lower socioeconomic status, that the maternal mortality for Black birthing moms is higher. And for some populations, while having being a higher socioeconomic status is protective, it's not it's not the same for our Black birthing moms.
So we've ruled out socioeconomics, right? So what are some other stubborn systemic barriers that continue to impede significant progress in reducing these rates? What have we identified?
Definitely some of the things that we've identified, like your question suggests, is that we have this longstanding history in this country of inequitable care. And I think that is persistent. And I know that the health system is trying its best.
So Northwell Health.
Northwell Health is trying its best to narrow those inequities. But it's always a challenge. And I use myself as an example. We all have implicit bias. And I think when we acknowledge that and acknowledge that that's present, I think that helps and it goes a long way in when we see a patient in front of us, how we treat that patient. My hope is that instead of looking at the person in front of you, treating the medical condition, and that the treatment should be not the same, but should be aimed at really treating the patient in front of you, as opposed to, attaching certain values to the patient in front of you. And I think that's important is listening to patients and giving them the care that they want and the care that they deserve. We also know that pre-existing medical conditions also contribute to maternal morbidity and mortality. So I think it's multifaceted, and there isn't one thing that's going to improve the care. But I think, if I think about it, I think standardizing the care. Say someone comes in with chronic hypertension and they have an elevated blood pressure, making sure that that blood pressure is treated, as opposed to saying, maybe that person has anxiety, maybe they're stressed, and that's why, the pressure is high, and then, kicking the can down the road, as opposed to having that immediate treatment that we know is going to help the patient.
So are you suggesting checklists, algorithms? What are you suggesting?
I'm suggesting having, if you want to use the term, a checklist. I think that's a good idea. And I'll just give
you... Or
you...
standards of care.
Exactly.
For different presentations then.
Right, because we know that algorithms, they can also hurt.
Have their own biases.
They have their own biases. So I don't want to shy away from using the term algorithm. As an example, we know for patients who need a renal transplant, that one specific number is looked at, and how the kidney functions. And we know that there was a fudge factor that was added, which put Black patients down to the bottom of the list. And once that fudge factor was removed, then more people of color were able to have or be eligible for renal transplants. So often when algorithms use race as in there, often it itself inherently creates bias. So I stay away from the algorithm, because that can also be biased.
How about we listen more to patients, because they know their bodies? And
absolutely. And I've said this before. I had someone who relayed her own story about her pregnancy journey, and one of the things that she said that stuck with me is that when you're in a consultation with a physician, there are two experts in the room. There's the medical expert and the patient, because you are the expert where you're concerned. And so it's important that you get your message across. And we always say, if not, bring someone else with you to the visit, someone who can help to get across your points, whether that is, the trusted other or the third, having that person in the room to help to get your point across so that, as you said, so that the patient can be heard.
Absolutely. So I know we jumped into some strategies to, to address some of these issues, but let's go back a bit. In prior conversations, you mentioned that New York is getting some things right about Black maternal health and mother-baby care more generally. What are some examples of that? And what could the rest of the country learn from New York's example?
I often say that I think I'm very fortunate to practice in New York State because there's so many programs that are available for pregnant moms. So one of the things that New York State recognizes that there are some hospitals that give a higher level of care. So they created regional perinatal centers, which at Northwell, North Shore University Hospital is, and Long Island Jewish Medical Center is also a regional perinatal center. And what that means is that there are hospitals within that network who may not have the resources. And so those hospitals, when they need care for a mom who's sick or a mom who might be going into preterm labor, less than 37 weeks, less than 32 weeks, those moms are transferred into those regional perinatal centers like North Shore University Hospital and Long Island Jewish Medical Center, so that moms can get that care and that specialized care that they need. And if the babies need a neonatal intensive care unit specialist, they're brought into a hospital where babies can get that care. And I think New York State has gotten that right. I know specifically where OB is concerned, New York State has the Safe Motherhood Initiative, where they're focused on maternal hemorrhage, where they're focused on preeclampsia, where they're focused on thromboembolism in pregnancy, blood clots in pregnancy, standardizing the care for those patients. And when you look at maternal mortality rates, it's evident how some factors like hemorrhage that were the leading cause of maternal mortality, because of the work that's done by the state, how that has dropped as the leading cause of maternal mortality. Now, there are other things now that are on the rise that we can see that are possibly causing maternal mortality. We know behavioral health conditions, we know cardiovascular disease, substance use disorders. So those are also now the focus of New York State, now that those conditions are becoming more evident as contributors to maternal mortality.
It's great to hear about all the amazing progress that has been made in New York, but what still needs improving? Do you think there are other areas that we can improve upon in New York?
One of the things that they commented on is that they have a lot of initiatives, a lot of things that they recommend, but they have no way of making sure that those recommendations or those programs are implemented by different hospitals. So I think that's where, now that work that needs to be done is encouraging hospitals to implement a lot of the suggestions that they know will help to improve maternal morbidity and mortality. And I think a lot of it as well is they recognize that some hospitals are not as under-resourced. And we know that there's an issue with hospitals closing, because of inadequate funding. I believe using telehealth, that can also help rural hospitals that are in need of certain services. So I think even though we've improved, we still have a long way to go.
Yeah. Well, I'm sure with experts like you and others working on this, we will get there, but some good progress made. You mentioned before behavioral aspects of mother and baby care. What's new there, and what's coming and what still needs to be addressed?
One of the things, we do know is that we don't have enough behavioral health professionals to treat our nation. So not necessarily specific to maternal health, but just to treat all populations that have behavioral health issues. But understanding that, New York State developed Project Teach, which is a program that is headed by someone here at Northwell, Dr. Dilla Giannidis. And so that Project Teach allows a practitioner like myself who has a patient in front of me who's in crisis to give me the tools that I need in order to help that patient. And then it also puts the patient in contact with behavioral health services that they can help to guide that patient to help them with whatever they need, whether that might be psychotherapy, whether that might be pharmacotherapy. And so that program is staffed 5 days a week from 9 to 5, that if we're seeing someone in the office and we have any questions about medication starts or where do I go or how do I refer the patient, that's available to us. As well, Northwell Health has started a behavioral health navigation program that we can also refer patients to that program if they're in need of behavioral health. And New York State has also developed an app for patients who might have behavioral health needs that they can also access resources through that app. And so those are the ways that the state is stepping in and the health system is stepping in to help patients who have behavioral health issues, with the recognition that we don't have enough personnel and it's going to be difficult to train all these personnel to help the need that we have. The staff that you have when you're in labor is really important, because oftentimes we focus on the physician alone, but who your nurse is also important. And maybe having a support person like a doula while someone is in labor may also help with increasing the chances of someone having a vaginal delivery. So those are all of the factors that we're looking at to see how can we decrease that rate and ensure that patients are not having unnecessary cesarean deliveries.
So we touched on some solutions before, but I'd like to go deeper. So to tackle these deep-rooted issues that you mentioned earlier, what concrete systemic steps do healthcare systems, policymakers, and communities need to prioritize right now to create safer outcomes for Black mothers across the nation? What policy changes do you advocate for?
I think one of the biggest things is access to care. And we know that our entire health system is based on whether someone is insured or not for them to get care. And I think one of the biggest things is for us, I think, and I know this is economic, but finding a way to provide care for patients who may not be insured or patients who are underinsured. I think that is a huge thing. One of the things that New York State has done is extend Medicaid for 1 year postpartum. I think that is a great policy that should be implemented across the entire United States. And not all states have expanded their Medicaid coverage for postpartum care for 1 year after delivery. And the reason why that's important is when we talk about maternal mortality, close to 62 to 65% of maternal mortality occurs after 42 days postpartum. So the vast majority are occurring later in pregnancy, after someone has delivered. And that expansion in postpartum Medicaid, we believe, will go a long way in helping patients get the care that they need in that 1 year after delivery.
See, that's important, because I think when we talk about maternal mortality, people don't usually factor in after someone gives birth. They think, once they give birth, before they even leave the hospital, then it ends there.
It does not. And so that's why I think that having that policy will help. One of the things that we talk about in pregnancy are adverse pregnancy outcomes, APOs. A mom who develops preeclampsia during pregnancy, a mom who has placental abruption, meaning that their placenta is separated from the uterus. They have a lot of bleeding and they end up delivering early because of that. A mom who has gestational diabetes. Those are risk factors in pregnancy that predisposes the mom to developing cardiovascular disease later in life. We know someone who has gestational diabetes, they're more likely to develop type 1 diabetes later on in life. About 25% of moms will develop type 2 diabetes within 10 years after that diagnosis. We know moms who have chronic hypertension, preeclampsia, those moms are prone to develop cardiovascular disease later on in life. And I think, what is happening, which hadn't been happening before, is that there are other medical specialties, especially cardiologists, that are recognizing that these adverse pregnancy outcomes need to be monitored after someone is delivered. And so, normally what would happen is we would say you come for your 6 weeks or your 8-week postpartum visit and you're done.
That's it.
But those patients, they need to have that follow-up care. And so I think that's where that, communication with our partners in other subspecialties will help moms down the road, because those mortalities, they can occur 1 year after. And so being able to give that warm handoff, as we talk about, to subspecialists who understand that those pregnancy complications are risk factors for complications in a person's life long after pregnancy, I think having even that recognition, I think goes a long way in terms of helping to improve the maternal mortality rates.
Absolutely. And that definitely that 1 year extension of insurance coverage does as well. Are there any other concrete systemic steps? Access to care, very, very important. Anything else?
One of the struggles, like we've always said, is the systemic and inherent inequality in the healthcare system. And I do believe that if a health system looks at metrics and looks at outcomes, I think that will go a long way in terms of improving or diminishing the inequities that we see in the coverage in the healthcare that patients receive. You mentioned the Birth Equity Improvement Project that New York State is conducting, which is now renamed Respectful Care and Promotion of Safe Vaginal Birth. And one of the things that's recognized is that there is a difference in a mom who's pregnant for the first time, their cesarean delivery rate. And we know that for Black birthing moms, that cesarean delivery rate is higher. And the state recognizes that. And so they're trying to collect data, look at the different RPC sites across New York State that are participating in this project to see, once we gather the data, can we identify reasons why the cesarean delivery rate for a first-time mom, that the rate is higher for Black birthing patients. And I think, and I know that it's only by looking at programs that focus on looking at, those issues that we can then figure out how can we then target that, and what are the drivers why there are certain populations that have a higher cesarean rate than other populations. And the reason why that's so important is that having a cesarean delivery, it increases your risk of bleeding, hemorrhage. It increases your risk of infection, increases your risk of having a hysterectomy, losing your uterus. So those are complications that can occur. And then also, once someone has a cesarean delivery with a subsequent pregnancy, there are also concerns about abnormal placental location in that pregnancy and more morbidity for a mom in the next pregnancy. So, I think focusing on issues, like that, shining a light on those differences and seeing how we can, what steps that we can use to impact, those outcomes. I think that's really important.
So that information is not available yet as to why. The research is ongoing now as to why
The,
more
yeah,
Black mothers
yes.
have C-sections.
First-time moms.
First-time moms
Right.
have
So that's the
C-sections.
focus. It's called the nulliparous term singleton vertex rate. And so we're looking at all reasons, how when the mom comes to labor and delivery, how their labor process is conducted, which moms are likely to have a cesarean delivery too early before they get into the active phase of labor. What kind of agents are moms getting, and also the staff that you have when you're in labor is really important, because oftentimes we focus on the physician alone, but who your nurse is
Yeah.
also important. And maybe having a support person like a doula while someone is in labor may also help with increasing the chances of someone having a vaginal delivery. So those are all of the factors that we're looking at to see how can we decrease that rate and ensure that patients are not having unnecessary cesarean deliveries.
Yeah. So I know that research is ongoing, or data collection assessment is ongoing, but do you have any early thoughts as to why this happens?
Some of I always want to say, let the data drive you. And
Yeah.
I think I'm pretty clear that there's some biases that enter into interactions when patients enter not just labor and delivery, but the
The
hospital.
hospital side.
And I think those are really harder to tease out. So that's why we talked about standardization and checklists before, that if we treat the condition the same way, then hopefully we will get rid of some of that implicit bias and some of those inequities. But some patients, we know that they end up with a cesarean delivery because of the fetal heart rate tracing is abnormal, versus some patients, they're like, I don't want to labor anymore, and so they request that they have that cesarean delivery. So I think those things we're still trying to find out.
All right. So, despite all the challenges and issues that you mentioned, there are things that mothers can do to advocate for themselves. So, for Black mothers listening, or for any woman listening, but particularly Black mothers, since they're disproportionately affected, what are the most crucial pieces of advice you can offer on advocating for themselves and ensuring they receive equitable, high quality care during pregnancy, childbirth, and postpartum? And also, what role can family, community, and support networks play in this advocacy?
So I'm going to take the question in a couple of parts. I think what's really important, if someone is thinking about planning a pregnancy, I think it's important to start even before you become pregnant, that if you have any medical condition, optimizing that medical condition, seeking what's called a preconception consultation with either a high-risk doctor like myself, if you have pre-existing medical conditions, or even if you're a healthy patient, talking to your primary care doctor, your gynecologist, and starting those conversations about how can I optimize my health prior to even becoming pregnant. And I think once you become pregnant, just doing your homework, I think before you go to your doctor appointment, think about what questions you want to ask and write those questions down. Because I know for me, this happens that you get there and in the moment and you're like, oh, I had a question and I forgot. So writing those questions down and making sure that you get the answers to those questions. And you mentioned, who else? Bringing your partner or a third, a church member or a cousin or whomever you feel can advocate for you and can help to get, what your goals of pregnancy are to whomever you're seeing for your care, whether that's an obstetrician, whether that's a midwife, so that those lines of communications are open. And, oftentimes, pregnancy, it's 9 months, but it's enough time for you to ask your questions and develop that comfort with your care provider. One thing I will say for pregnancy and labor and delivery is that we can have a plan of what we think should happen, but I tell my patients that labor and delivery, it's always unpredictable. So not to just focus on just this is the way I want it to be, because unexpected things occur while you're in labor and delivery. And I think if you form that relationship with your provider and that trust is there, then I think when things go awry, because sometimes that happens, that trust has already been built over the course of the pregnancy, that then you can be confident that your physician is, doing what's in your best interest. But I think it takes time that you're building that relationship before you get to labor and delivery. And once you get to labor and delivery, you're going to be meeting a bunch of people who are essentially strangers to you. And one of the things I just remember as a resident and as a fellow is knowing that you have this short time for someone to establish that trust with the patient. So I think what's important is when you walk into that room, introducing yourself, who you are, what your role is, and knowing the patient's history even before you go in that room when you're meeting the person for the first time. And I also think what's important is giving that person space to express, what they're feeling, what their hopes are for their labor and delivery, and understanding that as a team we can get there, because ultimately the goal is to have a healthy baby and a healthy mom, regardless of whether that birth is a vaginal birth or a cesarean delivery.
So that all sounds wonderful, Dr. Lewis, and optimal for if you're planning. But what about for those mothers who it's unexpected?
50% of pregnancies in this country is unplanned.
Right.
That we
unplanned,
do know.
Rather.
Yeah,
unplanned.
That we do know.
So what advice do you have for those mothers with unplanned pregnancy? So they don't have time to plan before, and they can still have their questions and develop that trusting relationship, but they may not know they have pre-existing conditions before.
Yeah, no, absolutely. And we always say pregnancy is a stress test. And so oftentimes conditions unfold that patients have no idea were existing, and we just give them the support and the care that they need. Because, oftentimes it's unknown to the patient. And we're fortunate to be in a health system where we have such multidisciplinary support around us, that if something unfolds, whether it's a cardiac issue, we have our cardio OB team. If it's a kidney issue, we have our nephrologist. If it's we have a cancer center, if it's a cancer that's diagnosed during pregnancy. So we're fortunate to be here in Northwell, but whatever happens, we're here to support the patient. And oftentimes it's a shock, whatever that new diagnosis is. And sometimes that information is not received. And, we have to help patients process that information and to help them to get the best care that they need in those situations.
So I think what I'm hearing in both situations for patients, whether it's planned or unplanned, is to make sure you have the right team around you. Have a support person. If you don't have a partner, you bring a friend, a church member, a community member, whoever you trust to be there with you. Be curious, be present in your journey, have your questions answered. And if you're not satisfied with the care team, then you find somebody else that you can trust.
Yeah, absolutely.
Right?
And I would be remiss without mentioning our partners in community wellness and population health that run the Moms Navigation Program for patients who enter pregnancy if they have pre-existing medical conditions. That Moms Navigation Program, they help patients in our system coordinate the care that they need. And recently, we started a community health worker program where we have community health workers that are in some of our prenatal clinics that if patients have any issues that they need help with, nutrition, SNAP, immigration, that those transportation, that those community health workers are there to help our patients.
So you mentioned having a multidisciplinary team, and I recently read an article in the New York Times where you were, quoted in the article several times, along with many of our other amazing physicians. And this was teamwork at its best. I mean, it was just so touching and great outcome for the mom.
I have to say that the patient herself, she was impressive.
Very impressive.
She had a lot of knowledge about her medical condition. And for her, it was important that we were all on the same, wavelength, that whatever was happening, that there was conversations with her about any changes in her healthcare, any changes in the plan, any changes in the medications, and asking, her for her input and how did she feel and what did she think about, what our suggestions were. And so
so just briefly give a little synopsis of the clinical condition and the complexities and how it was important that she had this multidisciplinary team.
Right. So our patient, Ms. Shepard, has lupus and had an end-stage renal disease because of her lupus. And so very early in her pregnancy, at 14 weeks, was hospitalized because she needed dialysis 5 to 6 days a week. And she had not been on dialysis, prior to the pregnancy. But once she got pregnant, we discussed with her the risks to her and to her baby and the possibility that her renal condition could worsen because of the pregnancy, which it did. And at 14 weeks, she was admitted to the hospital for dialysis. So our nephrology team worked closely with us. Our nursing team on labor and delivery and on our antepartum unit, they work closely with us to help manage this patient. And we didn't know, how the pregnancy was going to unfold. We could talk about the risks, but we didn't know if they were going to happen, when they were going to happen. And for our patient, she did well throughout the pregnancy.
Obstetrics also
absolutely
was a part of this, right?
Yeah, because after she also had some complications after she delivered where her heart failed, and our cardio obstetrics team was there to help her, and her heart recovered. And luckily for our patient, she had a transplant about 1.5 years after her delivery, and now is on the road to recovery. And I attribute that to her. She's phenomenal patient, and was really someone who advocated for herself and for her baby. But she also had a team of physicians that listened to her, and she had that expert care, that multidisciplinary care that we could provide for her in the healthcare system.
Amazing. So despite these profound challenges, what gives you hope for tangible improvements in Black maternal health outcome? What gives you hope for tangible improvements in Black maternal health outcomes in the near future?
What gives me hope is that I remember starting out as a young maternal fetal medicine physician, and most other disciplines in medicine just being afraid of even seeing a pregnant patient. And over the course of my career, I have seen that change, where there's so many people and so many other disciplines who are now invested in pregnant care and taking care of the pregnant mom, which was not there, I would say, at the beginning of my career in maternal fetal medicine. So I think that is promising, where cardiologists are now involved in maternal care, and every other discipline, oncology, nephrology, and that they're actual experts in those fields who actually love to take care of pregnant patients, with something that was missing when I started my career in maternal fetal medicine. So I'm hopeful that is going to expand, And that's just going to continue, where a pregnant woman is not treated as other and is just included in any other patient that needs medical care, and is not given the care they need because they're pregnant. And I think that makes me hopeful that, that's what's happening now.
Amazing. Well, Dr. Lewis, thank you so much for joining us today on 20 Minute Health Talk, for your perspectives, just for your service. You talk about this and you are beaming, you're smiling. So I know you're totally invested. And to our listeners, thank you so much for joining us. This has been another episode of 20 Minute Health Talk. Until next time, be well.